Hello, in this tutorial we're going to visualize ECG interpretation of coronary artery diseases. Now, for ECG interpretation of coronary artery disease, we have to first know the different coronary artery syndromes. The coronary artery syndrome are divided into two. We have acute coronary syndrome and we have chronic coronary syndrome. Basically, under acute coronary syndrome, we have myocardial infarction, which can be divided into SC segment elevated myocardial infarction STEMI and non-SC segment elevated myocardial infarction non-STEMI. Still in acute coronary syndrome, we have what is called unstable angina. Now, in chronic coronary syndrome, we have what is called stable angina, and then we have what is called a Prince-Metal angina. So those are the different elements that you have to visualize. You have stable angina, you have Prince-Metal angina, which are associated with the acute coronary, which are with chronic coronary syndromes. Now, we need to know that each of them have different presentations on the ECG. Each of them have different presentation of the ECG that I'm going to tell you. Now, we need to know that for the STEMI, S segment elevated myocardial infarction, generally on the ECG, you're going to have SC segment elevation. And that SC segment elevation is associated with also a T wave inversion. So generally that is going to be for a STEMI. And then for the pathophysiological aspect of the STEMI is that what? For an S segment elevated myocardial infarction, generally you have a transmural infarction. You have a transmural infarction, meaning that it is the whole wall of the heart that is affected, from the endocardium going to the myocardium, going to the epicardium, and lastly the pericardium. So the pericardium is much more with a pericarditis, so it's not involved here. So it is from the endocardium, myocardium to the epicardium that you have the infarction. So it's a gross infarction at the level of the heart that you're going to have an S segment elevated myocardial infarction. Now, the next point after the S segment elevated myocardial infarction is what is called non-SC segment elevated myocardial infarction. Now, non-SC segment elevated myocardial infarction, unstable angina, and stable angina, all of them have what is called ischemic signs on ECG. So we have what is called ischemic signs on ECG. And now, what are ischemic signs on ECG? The first ischemic sign on ECG is a SC segment depression. So S segment depression is going to be shown on the ECG for non-S segment elevated myocardial infarction, stable angina. Now, after SC segment depression, the next point, you are going to have a tall T wave. It is not peak, it is just a tall T wave. And now, the difference between this tall T wave and the tall T wave in hyperkalemia is that in hyperkalemia is going to be peak. Peak means that it's going to have a pointed apex, the pointed amplitude. That is the peak. Why here in the case of ischemic signs is just going to be tall. And then the next point after tall T wave, for that distinguishes hyperkalemia from the ischemic signs, is that for hyperkalemia is going to be diffuse tall peak T wave, while in the case for ischemic sign it's just going to be localized into contiguous leads of a particular aspect of the heart that is affected. Is it clear? Now, after the tall T wave, the next one is you have an inverted T wave. So inverted T wave is also going to be associated. So here they are going to be localized and they are much more on two consecutive or contiguous leads that affect one particular side or two sides of the heart. Basically, so those are the different things that you have to know as ischemic signs. Now, the question now is, since non-SC segment elevated myocardial infarction, stable angina, and stable angina, all of them show the same ischemic sign, how do you distinguish them? Now, the first element is to distinguish unstable angina from a non-STEMI. Is it clear? Unstable angina from a non-stable. Now, unstable angina and non-stable, in order to distinguish them, you have to measure the cardiac enzymes. Is it clear? An example of cardiac enzyme, we have the troponin ICT, we have the creatinine phosphokinase. Is it clear? So those are different cardiac enzymes that can be measured. In the case of a non-STEMI, these cardiac enzymes are going to be elevated, while in the case of an unstable angina, they are not going to be elevated. Why? Because in non-STEMI, there is a myocardial infarction and the death of the cell results to a release of these enzymes. Is it clear? Now, for the physiology of a non-STEMI is that it's not going to be transmural. It's just one aspect of the heart that is affected. It can either be the endocardium, the myocardium, or the epicardium that is affected, and not all transmural like in a STEMI. In unstable angina, you just have an infarction that is not associated with rest. Is it clear? Clinically, the patient has an infarction associated with that's not associated with their exertion. It means that it is unstable angina. So he has a chest pain that is increasing in character, but not associated with exertion. Is it clear? So those are the different things. It can occur at the level of the rest. Is it clear? But here we don't yet have a myocardial infarction. Now, in a case, how do you distinguish now from unstable angina from stable angina? To distinguish unstable angina from stable angina, you use clinical significance, the clinical manifestation. Unstable angina is going to be associated at rest. There is no exertion that prompts it. It can come at any time at rest, while stable angina is associated with exertion. Is it clear? So that's the typical clinical characteristic that we have for stable and unstable angina. Now, the next element is that for unstable angina, in order for you to evaluate it, you are going to use what is called a 24-hour monitoring of the monitoring ECG. Is it clear? The Holman ECG, 24-hour monitoring ECG, such that even when the patient is at rest, you can visualize the ischemic sign. Why? In order for you to visualize stable angina, you use a stress or exercise ECG on the treadmill. Is it clear? Or other exercise with the appropriate cardioversion methods in order to prevent any prompt attack and other drugs. Is it clear? So those are the different things that you have to know when you want to distinguish each of these pathologies. The last element is what is going to be called a Prinzmetal angina. Now, Prinzmetal angina is specific because in addition to the ischemic signs of the ECG, it has ST segment elevation. Surprising. So in Prinzmetal angina, you have what is called an ST segment elevation. Is it clear? But that ST segment elevation is not associated with an infarction. Is it clear? So in this case, you have a patient that has an ST segment elevation, but when you evaluate the cardiac enzymes, there is an absence of the cardiac enzymes in blood. This is because in Prinzmetal angina, you have an intermittent complete occlusion of the physiology of the Prinzmetal angina. It is an intermittent complete occlusion, vasoconstriction. Is an intermittent complete occlusion of the coronary arteries as a result of vasoconstriction of the smooth muscles. Is it clear? So that is the Prinzmetal angina. Is it clear? It is that the reason why it is intermittent is because that is why it does not cause a myocardial infarction. Is it clear? It is intermittent, means that it constricts and then it relaxes. Is it clear? Without causing any myocardial infarction. That's why, since there is a vasoconstriction, the best method of doing a reperfusion, that is the principle of management of myocardial infarction, is going to be a reperfusion plus a reduction in cardiac activity. Is it clear? That's why the best reperfusion method in Prinzmetal angina is going to be to relax this vasoconstriction. Is it clear? And the best way to relax this vasoconstriction is by using calcium ion channel blockers. Is it clear? So you use calcium ion channel blockers in order to stop this vasoconstriction. Is it clear? So from here, we finish with the first point of the coronary artery disease pathologies. We now move to the next aspect, which is going to be the pathologies of the conductivity.